Assalamualaikum and a very good day. We will continue our Perak Trauma Life Support lecture with head trauma. Hi, I'm Dr. Sabrina. I'm emergency physician from Hospital Raja Permaisuri Bainun, Ipoh. Okay, in this lecture, basically there are 4 objectives that you should learn. Number 1 is to describe the intracranial anatomy and physiological survey and resuscitation of patients with traumatic brain and head injuries. Number 3 is to describe the components of a focused neurological examination. And number 4 is to describe the target resuscitation parameters in limiting secondary brain injuries. So basically, let us review the anatomy of the head. Okay, the cranial anatomy consists of scalp, skull, meninges, brain, ventricular system, and also intracranial compartment. When we talk about scalp, okay, there are 5 layers of the scalp, which also, if we want to tell with regards to mnemonic, we have got the mnemonic of scalp also, which is actually the skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. So the scalp has generous blood supply. Scalp laceration can cause significant blood loss, which lead to hemorrhagic shock, even death, especially in pediatrics. So that's why if there's a significant scalp laceration, we might need to do a hemostatic suturing before transfer, right? Okay, what is regarding the skull? Okay, the skull composed of cranial vault and also the base. Okay, it is the most thinnest at the temporal region, hence easily fractured. Okay, the base of skull is irregular and it is easily injured by acceleration and or deceleration injury. The floor of the skull is divided into 3 fossas, which is the anterior, middle, and also posterior fossa. With regards to meninges, meninges covers the brain and it consists of 3 layers. The mnemonic is DAP, which is the dura mater, arachnoid, and also pia mater. Right. With regards to the dura mater, it is the outer layer, which is tough fibrous membrane that adheres firmly to the internal surface of the skull. It has fixed sides. The dura splits into 2 leaves and enclose large venous sinuses, which are major venous drainage from the brain. The midline superior sagittal sinus drains into the bilateral, transverse, and sigmoid sinuses. Meningeal artery situated between dura and the internal surface of the skull, that making up the extradural space, and fracture of the skull can lacerate these arteries and cause extradural hemorrhage. Most common is the middle meningeal artery located at the temporal fossa. Okay. With regards to arachnoid matter, okay, it is a transparent layer. It does not attach to the underlying arachnoid membrane, okay, and it possesses a potential space between these layers that exists, that we call it as a subdural space, into which hemorrhage can occur. The surface of the brain to the venous sinuses within the dura mater may tear, leading to the formation of a subdural hematoma. Next is pia mater. Pia mater is firmly attached to the surface of the brain. The cerebrospinal fluid fills the space between the watertight arachnoid mater and the pia mater, which is also called the subarachnoid space, cushioning the brain and the spinal cord. Hemorrhage into this fluid-filled space, or subarachnoid hemorrhage, frequently accompanies brain contusion and injuries to major blood vessels at the base of the brain. Now we come to the brain. The brain consists of cerebrum, brainstem, and also cerebellum. Okay? The cerebrum composed of right and left hemispheres, which are separated by falx cerebri. The left hemisphere contains the language centers in virtually all right-handed controls executive function, emotion, motor function, and on the dominant side, expression of speech. The parietal lobe directs sensory function and spatial orientation, whereby the temporal lobe regulates certain memory function and the occipital lobe is responsible for vision. The brainstem is composed of midbrain, pons, and medulla. The midbrain and upper pons contain the reticular activating system, which is responsible for the state of alertness. Vital cardiorespiratory centers reside in the medulla, which extend downwards to connect with the spinal cord. Even small lesions in the brainstem can be associated with severe neurological deficit. The cerebellum, responsible mainly for coordination and balance. It projects posteriorly in the posterior fossa and connects to the spinal cord, brainstem, and cerebral hemisphere. The ventricles are the system of CSF filled spaces and aqueducts within the brain. CSF is constantly produced within the ventricle and absorbed over the surface of the brain. The presence of blood in the CSF can impair its reabsorption, resulting in increased intracranial pressure. Edema and mass lesion, for example, hematomas, can cause displacement or shifting of the normally symmetric ventricles, which can readily be identified on brain CT scan. Now we'll go to the intracranial compartment and brain herniation. Okay. Tough meningeal partitions separate the brain into regions. The tentorium cerebelli divide the intracranial cavity into supra The midbrain passes through an opening called the tentorial hiatus or notch. Okay, here, right? The oculomotor nerve or cranial nerve tree runs along the edge of the tentorium and may become compressed against it during temporal lobe herniation. Parasympathetic fibers that constrict the pupils lies on the surface of the third cranial nerve. Compression of these superficial fibers during herniation causes pupillary dilatation due to unopposed sympathetic activity, often referred to as a blown pupil. The part of the brain that usually herniates through the tentorial notch is the medial part of the temporal lobe, known as the uncus. Uncal herniation also causes compression of the corticospinal pyramidal tract in the midbrain. The motor tract crosses to the opposite side at the foramen magnum, so compression at the level ipsilateral pupillary dilatation associated with contralateral hemiparesis is the classic sign of uncal herniation. Okay. Rarely, the mass lesion pushes the opposite side of the midbrain against the tentorial edge, resulting in hemiparesis and a dilated pupil on the same side at the hematoma. Now we go to the intracranial pressure regulation physiology. Okay. We will talk about ICP regulation. Elevation of intracranial pressure can reduce cerebral perfusion and cause or exacerbate ischemia. The normal ICP for patients in the resting state is approximately 10 millimeter mercury, and the pressure greater than 22 millimeter mercury, particularly if sustained and refractory to treatment, are associated with poor outcome. Mechanism to maintain ICP. Now let us actually see what are the Monroe-Kelly doctrine principle. The Monroe-Kelly doctrine principle is a simple yet vital concept that explains ICP dynamics. The doctrine states that the total volume of the intracranial content must remain constant because the cranium is a rigid container incapable of expanding. When the normal intracranial volume is exceeded, ICP rises. Venous blood and CSF can be compressed out of the container, providing a degree of pressure buffering. Thus, very early after injury, a mass such as a blood clot can enlarge while the ICP remains normal. However, once the limit of displacement of the CSF and intravascular blood has been reached, ICP rapidly increases. For clinical purposes, cerebral perfusion pressure, or CPP, is defined as the mean arterial blood pressure minus intracranial pressure. Or we can also call CPP is equal to MAP minus ICP. Okay. An MAP of 50 to 150 millimeter mercury is auto-regulated. You can see over here, it's auto-regulated to maintain a constant cerebral blood flow under pressure auto-regulation. Severe traumatic brain injury can disrupt pressure auto-regulation to the point that the brain cannot adequately compensate for changes in CPP. So in this kind of situation, if the MAP is too low, the ischemia and infarction can occur. But if the MAP is too high, marked brain swelling occurs with elevation. Okay. Cerebral blood flows also constrict or dilate in response to changes in the partial pressure of oxygen and partial pressure of carbon dioxide in the blood. We call it as chemical autoregulation. Okay. Therefore, secondary injury can occur from either hypotension, okay, hypoxia, hypercarbia, or iatrogenic hypocapnia. Okay. We must make sure to make every effort to enhance cerebral perfusion and blood flow by reducing elevated ICP, maintaining normal intravascular volume and MAP, and restoring normal oxygenation and ventilation. Hematomas and other lesions that increase intracranial volume should be evacuated early. Maintaining a normal CPP does not equate with or ensure adequate cerebral blood flow. Once compensatory mechanisms are exhausted and ICP increases exponentially, brain perfusion is compromised. Okay. Now, for classification of head injury, we can classify based on severity, based on morphology, and another one is based from the mechanism. If we want to classify the traumatic brain injury into severity, we can classify it into mild, moderate, or severe based on the GCS classification. If we want to classify the TBI based on morphology, it can be further subdivided into skull fracture, which are either VOC or basilar skull fracture, or based on the intracranial lesions, whether they are focal intracranial lesion or diffuse intracranial lesion. If we want to classify the TBI based on mechanism, it will be either blunt or penetrating head injury. Okay. Scoring is very important. So I think by now you should actually know what are the components of the GCS scoring, which is we take it as a best eye opening response, best verbal response, and also best motor response. Total of the GCS scoring is 15. The maximum score is 15. The minimum scoring is 3, right? In the presence of right or left asymmetry, use the best motor response. GCS scoring must be done prior to sedating or paralyzing the patient. Avoid using long-acting paralytic and sedating agent. Okay. How to assess the response to painful stimuli? You can either elicit the movement using central pain or peripheral pain. For central pain, you can do trapezius pinch, supraorbital pressure, or sternal pressure. Whereby, for peripheral pain, you can elicit it by nail bed pressure. In skull fracture, few signs that you need to look for, basically or specifically for basilar skull fracture, which is the hemotympanum, battle sign, and also raccoon eyes. Do not underestimate the significance of a skull fracture because it takes considerable force to fracture the skull. And another one thing is that in basal skull fracture, rather common or uncommon to have a 7 facial nerve palsy that may occur immediately or it can occur a few days after initial injury. So that's why if we have this kind of patient, we must also refer to our ENT colleague as well, right? For cerebral concussion, okay, depends on the guidelines that we use. So basically, we have got 3 severity of cerebral concussion, whether it is mild, moderate, or severe, right? The gradings. The presence or not presence of loss of consciousness, confusion, and also the duration is very important to grade the severity of the cerebral concussion. Okay, intracranial lesion can be divided into focal lesion or diffuse brain injury. For focal lesion, we are actually seeing the focal lesion such as intracranial hemorrhage based on the site of the lesion. But in diffuse brain injury, normally what we can see is that the CT brain is basically normal. You may see small white dots here and there, normally involving the acceleration, deceleration type of injury with shearing force. The patient typically will present to us with poor GCS, but with so-called normal CT scan, and the treatment is basically based on GCS, ICP, and CPP monitoring. And it is very paramount important to repeat the CT brain after 24 to 48 hours to reassess the trauma that may be present. Okay, for the general management of the head trauma, in primary survey, I think all of these are actually paramount important, but head trauma, we are assessing the D particularly. We must determine the GCS scoring, pupillary light response, focal neurological deficits, and whether there's any presence of drug, alcohol, and intoxicant influence. In secondary survey, ample is very important, okay? And also reassessing back your GCS scoring and re-evaluate back the pupillary response and evaluate the upper and lower extremities for motor and sensory functions and observe if there are new lateralizing signs. And the secondary survey adjuncts include CT brain and also CT cervical spine. Okay. We go to the next part in the management of score between 13 to 15. Often, patients have sustained a concussion, which is a transient loss of neurologic function following a head injury. All right. Definition of a mild head injury is patient that is awake and may be orientated with GCS of 13 to 15. For the history, you have to elicit all these, right? Okay, and then you have to examine the patient and do limited neurological examination and do primary survey X-rays and obtain a bedside urine tox or blood alcohol level if indicated or if needed by the police officers. And after that, CT scan of the head is indicated if the criteria is fulfilled. So we will see what are the criteria for CT brain in mild head injury. Okay, in this table 6.4, it is stated that head CT is required for patient with suspected mild definite amnesia or witness disorientation in a patient with a GCS score of 13 to 15, plus any one of the following factors in high risk or moderate risk group. Okay. In high risk group, if the GCS score less than 15 at 2 hours after injury, suspected open or depressed skull fracture, signs of basal skull fracture, vomiting age more than 65 or anticoagulant use, any one of these, or in moderate risk, if there's any loss of consciousness more than 5 minutes, amnesia more than 30 minutes, dangerous mechanism, we must do a CT brain, right? Okay, then you will determine whether you want to admit or transfer to appropriate facility or discharge from the hospital. Okay, so this is the criteria for admissions or transfer. And if you want to discharge the patient from the hospital, make sure the patient does not meet any of the criteria for admission, and to discuss need to return if any problem develops. Explain to the patient, and also very important thing is to explain to the caregiver as well. And most of the time, the patient shall have a scheduled follow-up visit under neurosurgical clinic. In a Canadian City Head rule, it is stated that if we apply the parameters previously in table 6.4, in a GCS 15 patient, 10% will have CT findings. Okay, if we do a CT brain in GCS 15 patient that fulfill the criteria. Okay, whereby 0.5% for the 10% just now will require neurosurgical intervention. For GCS 13 patients, 25% will have CT findings, whereby 1.3% from the 25% will require neurosurgical intervention. Okay, what are the advice that we should give, okay, upon discharge? Okay, this is very important. Understand for them to seek medical attention for any of the following, which is actually change in level of consciousness, abnormal behavior, increased headaches, slurred speech, weakness, or loss of feeling in arm or leg, persistent vomiting, enlarged of one of both pupils, seizures, significant increase in swelling and injury site, and most important thing is do not prescribe sedative or stronger pain medications or aspirin base for the patient. How about management of moderate head injury? Moderate head injury encounters about 15% of head injury patients in ED. The patient basically able to follow simple command, but they usually are confused or somnolent and can have focal neurological deficit. 10 to 20% may deteriorate and lapse into coma. Thus, serial neurological examination are crucial or critical. Okay, these are the algorithm for moderate head injury. Definition of moderate injury is the GCS of 9 to 12. Initial examination is the same as what you must be obtained in all cases, and admit or transfer to a facility capable of definitive neurosurgical care. After admission, we must frequently check the neurological function. Most of the time will require follow-up CTs if the condition deteriorate, or preferably before discharge. And if the patient improve, which occurs 90% of the time, we can discharge with appropriate follow-up. In clinics, normally the patient will be discharged from the neurosurgical ward. If the patient deteriorates, which occurs in 10% of the cases, okay, the patient must be repeated, the CT brain must be repeated, and the patient must be managed as per severe brain injury protocol. Because kalau they deteriorate, basically the DCS is likely to be less than 9, which is 8 and below. Okay. For severe head injury, it comprises of 10% of head injury patients in ED. In these kind of patients, we will need aggressive cardiopulmonary stabilization, and the mortality rate for patients with hypotension on admission, hypoxia, in addition to the hypotension, is associated with an increased risk of 75% mortality, right? In severe head injury, it is defined as a GCS score of 3 to 8, okay? And we must approach the patient by algorithm, assessing the patient A, B, C, D, E, and treat the A, B, C, D, E, primary and secondary survey, and transfer to a facility that is capable to give a neurosurgical care to the patient. And normally we have to initiate the therapeutic agents for the patient, including whether need to give any mannitol, hyperban, hypertonic saline, and also frequent neurological re-evaluation with regards to GCS, pupillary, and focal neurological examinations. CT scan is mandatory. So we will discuss more after this. Okay. Basically, if let's say trauma already happened, so primary injury is there. So okay. So these are the head injury resuscitation targets. So basically for the under the airway and breathing, we want to protect the airway and intubate the patient early if indicated. And then avoid hypoxia, keep the SpO2 more than 95% with PaO2 of more than 100 millimeter mercury, and maintain normal carbia with PaCO2 of 35 to 45. In circulation, we must treat hypotension aggressively and keep the systolic blood pressure 100 to 110 millimeter mercury, and keep the hemoglobin level of more than 7, INR less than 1.4, platelet of more than 75, and keep the sodium level at 135 to 145. In disability, we must treat the seizure with anti-epileptic agent, and if indicated, to give mannitol or hypertonic saline with barbiturate and temporary hyperventilation if fulfill the indication. The 38 degree and avoid hypo or hyperglycemia, which is actually metabolite imbalances. Okay. In head injury resuscitation, okay, basically for anesthetic, sedation, and analgesia, we must use with caution. Low dose of IV narcotics may be given for analgesia and reverse with naloxone if needed. Short-acting IV benzodiazepines such as midazolam may be used for sedation and reverse with fumazanil if indicated. Okay. Overuse may cause impaired respiration, failure to recognize worsening of head injury, and unnecessary treatment, for example, intubation. Okay, so we discuss one by one medical therapies for head injuries. When we talk about medical therapies, we are talking about giving the patients intravenous fluids, correction for anticoagulant therapy, mannitol, hypertonic saline, giving patients barbiturate or anticonvulsant, and temporary hyperventilation. Maintain normal volemia. Okay. The aim is to resuscitate the patient, maintain normal volemia, and traumatic members to administer intravenous fluid, bloods, or blood products when required. Hypovolemia in patients with TBI is harmful. Clinician must also take care not to overload the patient with fluids and avoid using hypotonic fluids. Moreover, using glucose-containing fluids can cause hyperglycemia, okay, which can harm the injured brain. Ringer-slated solution and also normal saline is thus recommended for resuscitation. Carefully monitor the serum sodium level in patients with head injuries. Hyponatremia is associated with brain edema and should be prevented. Okay. For anticoagulant correction, okay, use caution in assessing and managing patients with TBI who are receiving anticoagulants or antiplatelet therapy. After obtaining the INR, clinicians should promptly obtain a CT of these patients. CT scan brain first lah, rather than actually waiting for the INR, then only do the CT scan. Okay. A rapid normalization of anticoagulation is generally required, especially if the patient is on anticoagulant therapy with prolonged INR. You want to correct it rapidly so that the bleed is not expanding. Okay, these are the anticoagulant and their reversal agent. Okay, so we must give the reversal agent correctly for those kind of anticoagulants because we have got plenty of anticoagulants in the market nowadays. Okay, for hypertonic solutions, okay, we have got mannitol and we have got hypertonic saline. Mannitol is a sugar base with potent osmotic diuretics, whereby hypertonic saline is a salt base with no diuretic effects. Okay, mannitol is used to reduce elevated ICP, and the most common preparation is a 20% solution. What is meaning by the 20% solution is 20 gram in 100 mils, okay, for 100 ml solution. So do not give mannitol to patients with hypotension because mannitol does not lower ICP in patients with hypovolemia. Hypotension and cerebral ischemia. So Acute neurological deterioration, such as when a patient under observation develop a dilated pupil, hemiparesis, or loss of consciousness, is a strong indication for administering mannitol in a euvolemic patient. In this case, give a patient a bolus of mannitol, 1 gram per kilo, rapidly, normally we will give about over 20 minutes, and transport her or him immediately to the CT scan to see whether got any worsening of the bleed or edema, okay? Or if the diagnosis is obtained earlier, okay, directly to the OT after we refer to the neurosurgical team, okay? If let's say the neurosurgical services are not available, so we must transfer the patients for definitive care to the tertiary center. Mannitol versus hypertonic saline. Okay, we have explained about mannitol. How about hypertonic saline? Hypertonic saline is until 23.4%. That is the most concentrated. This may be the preferable agent for patients with hypotension, as it does not act as a diuretic. However, there is no difference between mannitol and hypertonic saline in lowering the ICP, and neither adequately lowering ICP in hypovolemic patients. Okay, when you want to give a hypertonic saline, the much more percentage, you must use the central line IVSS. Okay. How about barbiturate? Barbiturate are effective in reducing ICP in refractory, that is refractory to other measures, but it is not to be used in the presence of hypotension or hypovolemia, because barbiturate itself can cause hypotension, thus is not indicated in the acute resuscitative phase. Okay. Anticonvulsant is actually used for because it is assumed that post-traumatic epilepsy occurs in about 5% of patients admitted to the hospital. So there are 3 main risk factors that predispose the use of anticonvulsant, which is seizures that occurring within the first week, intracranial hematoma or hemorrhage, or depressed skull fracture. So these are the indications for us to use a anticonvulsant. Okay. So normally we use phenytoin or sodium valproate. Okay, it is actually commonly used in the acute phase. Okay, the loading dose is 1 gram in a normal 50 to 70 kilo patient, intravenously given not faster than 50 milligram per minute. Okay, and maintenance dose is 100 milligram 8-hour D or TDS. We can use Valium or lorazepam as well. Okay. Anticonvulsant can inhibit brain recovery, so they should be used only when absolutely necessary. Okay. How about hyperventilation? Okay. In most patients, normal carbia is preferred. Hyperventilation. Aggressive and prolonged hyperventilation can result in cerebral ischemia in the already injured brain by causing cerebral vasoconstriction. Okay, and thus impact cerebral perfusion. This risk is particularly high if the PaCO2 is allowed to fall below 30 milligram mercury. Okay, hypercarbia, which is the PaCO2 of more than 45, will promote vaso-D and increase intracranial pressure and should therefore be avoided. Prophylactic hyperventilation is not recommended. It is class 2B evidence, and the use of hyperventilation only in moderation and for as limited as a period as possible. In general, it is preferable to keep the PaCO2 at approximately 35 to 45, and brief period of hyperventilation may be necessary to manage acute neurological deterioration while awaiting while other treatments are initiated. Okay. So basically, hyperventilation will lower ICP. Doctor can perform emergent craniotomy, right? So it is not usually we do the hyperventilation unless it is really indicated or necessary. How about the surgical management for head injury? So basically, surgical management is indicated in a scalp wound with excessive blood loss, where we must actually put hemorrhage control, and whereby we suspect CSF leak due to dural tear. So This requires surgical management. And also depressed skull fracture. If the depression is greater than the thickness of the adjacent skull, and whether the depressed skull fracture is associated with open and grossly contaminated, definitely surgical management is needed. Or when there are intracranial bleeding or mass with a degree of displacement of septum pellucidum of more than 5 millimeter, so therefore urgent surgical intervention is necessary. And whereby there are any penetrating brain injuries, basically CT and this is obviously will need neurosurgical intervention as well. Okay. So in summary, these are the goals of treatment of brain injury. The goals actually involve the clinical parameters, the laboratory parameters, and also the monitoring parameters. Some of it is available in emergency department. Some of it may be available in the ICU setting. Okay. With that, thank you.